Thank you all so much for joining us for today's webinar. This is our very first in the series for the Mental Health Awareness Month and the very first time we're doing this mental health awareness webinar series. So I'm just super excited. We have kicking off the series with us today is Drew Martel. Drew is an accomplished mental health professional with a master's degree in social work from the University of Iowa. His extensive experience in crisis intervention, suicide prevention, and mental health services combined with his military background, has positioned him as a respected expert and innovator in the field of crisis intervention. Drew has served as a therapist at Meadowlark Psychiatric Services, as well as previously serving as the Director of Crisis Services and the Chief Training and Clinical Officer at Foundations 2. So the chat is open. If you have any questions as we get rolling, please put them in there. And Drew, in the interest of time, I'm going to turn it right over to you.
Okay, thank you. I'm Drew Martel. I'll be facilitating our brief brief presentation today. It's on principles and innovation in community health, and the 70 years on is a reference to I think arguably the origins of community mental health. It's a little bit obscure because there was a lot of people working in different places, but I'll get into a little bit of the history here. I'd like to start off with a little parable by a guy named David Foster Wallace, who was an author, and he was giving a commencement speech in 2005 to the University of South Africa, and it's become quite famous. Some of you might know it. It's officially titled "This Is Water: Some thoughts delivered on an important occasion about living a compassionate life." And the parable itself goes something like this: one day, two young fish are swimming along when they pass an older fish going the other direction. The older fish nods at the younger fish and says, "Morning, how's the water?" The two young fish swim on a little ways before one looks at the other and goes, "What the hell is water?" See, this parable was intended to point out that often the most ubiquitous truths are the hardest to see and acknowledge. And the reason I chose this for this presentation, and when we talk about community health, is because for the vast majority of people in our community, there's very little awareness, including for many of us. We simply don't have a reference point to account for the degree to which mental health conditions and mental health struggles are prevalent in our workplace, in our families, in our country, in our state, and then at our local community level. This is the case because of historical precedent. It's the case because of stigma and taboo around mental health conditions, and varying other things. But the truth is, mental health conditions are like the water in this parable. They're all around us. People we know. Everyone here has been impacted by someone or themselves with a mental health condition. Sadly enough, David Foster Wallace himself would die by suicide in 2012. He's a really interesting guy. He wrote several books, one that was quite famous called The Infinite Jest. He was also very, very funny. As a writer for The Atlantic, he wrote a piece that I recommend anyone look up called The Supposedly Fun Thing That I'll Never Do Again, about his time on board a cruise ship. So prior to the 1950s, there really was no concept of community mental health. It simply didn't exist. We did have some social work movements earlier in the century, but really the idea of community mental health prevention, it simply would have been foreign at the time. There was no such thing as insurance reimbursement for treating mental health conditions. There was no national or statewide crisis lines. Group homes wouldn't have looked anything like a place where I'm guessing most of the people on this webinar today would send a family member or advocate to have someone placed. To give some historical context, in 1847, Iowa passed the Poor Law Act, which created county-run asylums. The goal here was to put some of the onus on counties. I think today you can actually still go visit the Johnson County Poor Farm, is what it was called. That's the photo up here at the top of these cells, which essentially was a place where mentally ill would be removed from their community. They'd be placed here, they'd be locked up. And largely, there was no treatment at the time. The idea was that by working on a farm, work alone might cure them, might not, but everybody needs to work, right? We have this Puritan background. Conditions varied widely between poor farms, but but far and away, we're probably not a place that we would see as an effectively putting a human being, which was part of the reason for their demise. In addition to that, the states nationally at the time, there was a great amount of movement to build state-run hospitals or asylums. I have a photo here from MHI Independence, which is still in operation, but not in any capacity similar to what it was when it was created in 1878. And interestingly enough, when MHI was created, the mission of it was, quote, to hold alcoholics, geriatrics, drug addicts, mentally ill, and the criminally insane. These state asylums are quite notorious for the way in which I'm sorry, I thought I was muted for a moment. I saw the mute thing and I was like, oh my gosh, this whole presentation I've been muted, but now I realize I'm not. So treatment in state-run hospitals is quite notorious. I'm sure many people here, maybe some of you have visited the museum at MHI or are familiar with their history, but all sorts of treatments that were quite awful, including alternating hot and cold water baths, injecting patients with heavy addictive sedatives against their will, with really nasty side effects. And then most notoriously was lobotomies were conducted at these state-run hospitals, again against clients' will, and with all of these things being ineffective and quite barbaric. Some patients were also sterilized. Some patients were sterilized for being mentally ill. And in fact, I believe the state of Iowa had a eugenics office in operation all the way up until the 1970s. Always like to look at treatments of the time just to give context to what things might have looked like before community mental health at an asylum. If you were lucky, let's take a mental health condition that existed into the early part of the 20th century, neurasthenia, which is just kind of a catch-all term. You can look at the diagnostic criteria here, which basically includes everything. You got muscle pain, maybe you have neurasthenia, you got depression, maybe neurasthenia, anxiety, irritability, digestive problems. Of course, in line with psychiatry of the time of the early 20th century, the belief was this was caused by the hustle and bustle of modern life, which actually might have been more accurate than other theories of the time, right? Anxiety can certainly be exacerbated by contemporary life. If you were lucky enough to be treated by a progressive treatment of the time like Silas Mitchell's, which was essentially bed rest, there were some funny aspects to it, such as a high-fat diet under the assumption it would fatten and redden you. Which somehow would lead to a cure. I've yet to uncover that side of it. And also, he would regularly order the consumption of 2 quarts of milk a day, because that was also very important. I have no idea why. To be quite honest, a treatment like this in an asylum actually sounds quite preferable to me. I think there's many people here who are like, yeah, if I have bad anxiety, I wouldn't mind being ordered into bed for several weeks and being fed. Massages were a part of it as well. On the other hand, there were some pretty nasty treatments that were also being utilized, experimented on humans at the time. Louis Yelland, who was working in England, inside in a state hospital, an asylum at the time, was pioneering electric shock therapy, electric heat baths. He invented machines that would force frozen limbs in hysteric patients, also a term we don't really use anymore in the mental health realm. He claimed to have cured 250 people of, quote, hysterical disorders in only a single half-hour session by using his treatments. One case study I looked up involved believe it or not, a World War I private. This is after the war, so we're talking about 1920s, 1930s, who underwent treatment by Dr. Yelland here, and his treatment included, he had been rendered mute at Salonika. So the soldier had been at the Battle of Salonika, and due to the horrors of the war, he presented with mutism afterwards. And so his treatment included, over the course of several months, electricity applied to the back of his neck, hot plates placed in the back of his mouth, hypnotism, of course, and finally applying electric currents to his throat and instructing him to walk around in a room repeating vowel sounds, which reportedly cured him of his mutism. My point being that largely that psychiatry at this time was quite barbaric, and efficacy is basically non-existent in terms of the treatments being rolled out. And then equally as horrific was that most of these patients were having this done to them against their will or with very limited informed consent. So I'm gonna get a drink. In the 1940s, at a nightclub in Boston, a fire would break out. This is in the middle of World War II. It would kill 500 patrons in about 15 minutes. This club itself has a really interesting history. It was ran by a mob boss. I do another presentation on that covers this in more detail on the history of crisis intervention. So if this interests you, I'm doing a couple of those presentations later this year at some conferences. But interestingly enough, at a nearby hospital, psychiatrist Eric Lindemann, he's the black and white photo, who was studying grief work in female patients who had hysterectomies, would go down and he would work with survivors of the fire. And a couple things that he noticed in working with them was that lay people, social workers, nuns, peers, although he didn't call them that at the time, were just as effective at supporting survivors as were medical professionals. After this fire, he would go on to become quite famous for his grief work here. And actually, while on a book tour, he would meet another psychiatrist by the name of Gerald Kaplan. He's the gentleman on the right here. And Gerald Kaplan would be like the OG fanboy. He was really into Lindemann's work, whatever that means, being really into it. The two would go to Harvard together, and they would end up working together. Gerald Kaplan himself had been doing research on crises and mental health conditions after World War II in Jewish migrants who were moving to Israel. And so he was studying the impact that had on their mental health. So these two would go to Harvard together. They would join up at a team, and they would actually end up lobbying a Robert H. Felix, director of the National Institute of Mental Health, and to then himself lobby a President John F. Kennedy, who 1 month before his death in 1963 would sign into law the Community Mental Health Act. A year later, Kaplan, again, the colored photo, would publish Principles in Preventative Psychiatry, which would become one of the foundations of community mental health prevention. Very interesting story these two have. Can't emphasize that enough. And so the Community Mental Health Act, really landmark legislation, major shift in how mental health care is being provided in the United States. Kennedy himself, at the time of signing it, would state that, quote, the goal of it was to cut by half within a decade or two the 600,000 persons now institutionalized for psychological disorders. Unfortunate might be the wrong word, but one of the driving reasons that Kennedy signed this into law actually was there was increased negative sentiment in the public on the cost of institutionalization. It was kind of like a if you build it, they will come type of thing. And so when the states built these hospitals, these mental health institutes like MHI, they then became filled up, and that was pretty costly treatment. And so the public wasn't necessarily concerned about the well-being of the individuals there, but they were very concerned about the cost. Among many things that the Mental Health Act did is the Community Mental Health Act, is it directly funded 1,500 community mental health centers, and that would include the actual physical construction of them and the staffing of them. And the initial act had 5 essential services that were included, and that is consultation and education for community and professional organizations, inpatient facilities, outpatient clinics, emergency response, and partial hospitalization. And the thing I think is amazing is these are basically the essential functions of community mental health still to this day. So really quite remarkable work that Kaplan, Felix, and Lindemann, and of course several others did in putting this act together. It's really a 180-degree turn and very progressive for its time. Additionally, it is worth noting, very important to mention, the mental health consumer movement of the 1960s and 70s was kind of dovetailing with the Community Mental Health Act. But unlike kind of the Mental Health Act being partially driven by the cost of these institutes, the consumer movement was a grassroots movement really led by people who had been, I'm going to use the term victims of the institutes. So these were individuals who had been sterilized. These were individuals who had been institutionalized for decades in some cases. And there was a really, really strong backlash against primarily the psychiatric establishment, as well as the conditions within the mental health institutions. And that's without even getting into things like sexual abuse of patients, physical abuse of patients, general neglect that all occurred within these mental health institutions. This movement also dovetailed with the civil rights movement of the 60s and 70s, also putting a lot of emphasis on the right of independence and the right to live in a community, and to be shown dignity and worth and respect. And so at its core, if some of you are probably familiar with Maslow's hierarchy of needs. When I think about community mental health, especially at the prevention and intervention level, I'm often thinking about the bottom two tiers of Maslow's hierarchy. We would throw housing in there as well. If you don't have a clean, safe house, nothing else really matters. And so a lot of community providers, a lot of community prevention really is looking at these kind of lower levels of uh, of Maslow's hierarchy. It really is doing the grunt work of human needs, and I say that with pride. Myself, having spent over a decade now in community prevention and community intervention. So what does this look like? Well, it looks like a contemporary community mental health care prevention. Looks like a spectrum of care, right? And so we have psychiatry, community treatment, BHIS services, behavioral health intervention services, outpatient therapy, peer support. And I highlighted that in red because that has been an ongoing movement, partially driven by the consumer movement, but it's been quite a battle for peer support services to get the recognition they deserved in terms of having someone with lived experience providing care to a person who's struggling and suffering. And so still today, this is a movement that's growing as part of community prevention, but it's a movement that I hope everyone here supports, and we continue to see more utilization of peer support in all of the services that are being provided in community prevention and intervention, because how powerful is it to be able to connect with someone who themselves has struggled and can relate in many ways. We also have outreach and education, which is very, very important. Crisis stabilization beds. I'm fortunate over the last 2 to 3 decades really to see a significant investment both in Iowa, in our communities, but also nationally in crisis services, which also fall under the prevention and intervention, community prevention and intervention category. And so we have phone chat and text, which what a wonderful way for a person to connect for support from their living room, right? It's very non-intrusive. It's a least intrusive intervention, which plays on the foundations of community prevention. Mobile crisis outreach, having counselors come to your home rather than having to go to them. They'll come to where you are. Co-responder programs, offering a different path than the criminal justice system potentially. And then access centers, we just have relatively new here in Eastern Iowa, a new model nationally over the last 1 to 2 decades, but no wrong door access points in the system for people to go get the support they need. We are very lucky in Eastern Iowa to have maybe one of the strongest systems for community behavioral health and community prevention, in my opinion. But I'm the presenter, so my opinion is the one that matters. I'm just kidding. And so, of course, you'll see lots of familiar providers that are in this realm, lots of wonderful, high-quality providers that we have access to. We have Abbey Center, Community. We have the 988 Crisis Line, which rolled out last July as a national initiative. And then I had already mentioned the access centers as another example of some of the very innovative ways that our communities, our community or our state have tried to build out this community spectrum of care. That said, from my experience, it's a system of dialectics. That is to say that we have come, no arguing that we have made massive strides in what community prevention and intervention looks like, and simultaneously there is so much more that needs to be done. This program growth, this kind of philosophical approach to community wellness is far from perfect. There are still pretty big divides between rural and urban settings. That is to say, if you're in an urban community, you have access to many more services than in a rural community, and Iowa has a lot of rural communities. And the quality of care in rural communities can also lag behind what you would get in an urban community. Transportation is no joke from those communities to get the support they need, like going to a DBT program at the University of Iowa if you live an hour away is a big deal. Constantly shifting funding puts massive stress on community providers, and I don't think you'll find a single community provider that won't agree with that. Iowa has, unfortunately, or fortunately, depending on your perspective, really shaken up funding repeatedly just in the last decade alone, which is again causes a lot of stress for providers. And if there's a lot of stress on providers, there's going to be stress on clients as well. Ambiguous outcomes. Unfortunately, there are still a lot of services being provided under the guise of community prevention that the efficacy and outcomes of them aren't clear. And this is partly due to the very low funding rates that they get. Low pay, high skill work is another one. The people doing this work are absolutely amazing people. We should be grateful we have them in our community, mostly social workers. But the pay is quite low. Burnout is quite high. It's hard work. And then we have this kind of pendulum swinging with institutionalization. The truth is that there are some arguments that perhaps in the community mental health movement, states and systems went too far in terms of deinstitutionalization, putting people who actually need that level of care back into their community, unable to get that level of care, leading to a higher level of suffering. And then lack of trained professionals. And this feeds in with the low pay, high skill work because there's such high turnover. It takes a long time to build the skills to work in these settings. And so frequently cycling through new staff leads to a lack of trained professionals. Just a quick glimpse at here's the MHDS regions that came about roughly 10 years ago. And here is where I was heading with its big overhaul, which looks like the dissolution of regions into these behavioral health districts. And then in addition to that, we still have a pretty fractured system. That is to say, siloed systems of care. We still have this really strange, in my mind, dividing line between substance use disorders and mental health. The two are absolutely integrated, and hopefully we continue to build integration. We still lack really robust care coordination. That is, any community provider is aware of this phenom where you have an individual you're working with in your community who's also might have interactions with the criminal justice system, the hospital system, and perhaps another provider. And ensuring that there's communication between all these providers to provide appropriate care coordination is another big struggle and area for innovation in community prevention and mental health. And the other thing I'd like to point out is one could make a pretty strong argument that when we defunded the mental health institutes and we moved to deinstitutionalization, we just made jails and prisons into new institutionalization. The data on the number of mentally ill that are housed in prisons in the United States, not just in Iowa, and jails is it's tragic. It's unbelievable. I don't think anyone wants this. And the other thing I would say is it's interesting to me that in the 1950s, citizens in the United States had a problem with the cost of institutionalized care at mental health hospitals, but nobody seems to have a problem with the cost of care at prisons, which, look up some state penitentiaries and see what their annual operating budget is to get an idea for how much money goes into those. But it's undeniable that a large number of mentally ill individuals are now housed in jails and prisons without appropriate care. I'm not saying this is the fault of correctional officers or law enforcement officers. It's a failure of the system to adequately provide other areas of care. And this is partly what's going to be covered in the upcoming Mental Health Summit at Kirkwood. We're going to talk about the sequential intercept model and some attempts at building out opportunities to divert people away from jail or prison. And then close to home for me, an area that I've worked in for most of my career, despite lots of advances in our understanding of the etiology of suicide, of what community prevention looks like, of really big investment in crisis lines and crisis care, we continue to see rising suicide rates in the United States, pretty much year over year. I think the preliminary data shows that last year, it's not like solidified yet, may have been one of the higher years in terms of suicide rates in quite a while. This really is perplexing because suicide is indicative, is a symptom of underlying issues, oftentimes mental health conditions, untreated mental health conditions. And so it points at, going back to the efficacy of the care we're providing, we really do need to ask what is effective in the community spectrum of care. How do we know it's effective? And can we then go and invest more in that level of care? Okay, I made it right about on time here. I'm just going to quick summary. This was a very brief, quick run through, and so I tried to choose my angles pretty closely here. Briefly went over the foundations of community mental health. Right, I discussed the Community Mental Health Act of 1963, the consumer movement of the 60s and 70s, and gave a little bit of historical precedent. Overall, I don't think anybody would argue that we want to go backwards in terms of the way we provide treatment to individuals who deserve dignity and respect and informed consent. That said, I mentioned some of the challenges that have come with innovations, and especially around funding, shifting funding strategies, and ambiguous outcomes as it relates to some of the services being provided to the community. And future directions for me really look at care coordination, robust care coordination within communities, as well as really trying to understand what, as well as getting away from jails and prisons as an institution for the mentally ill, which seems to have occurred somewhere in between all of this, and then ensuring that we are investing in community prevention initiatives that we know are effective. And so, right about 4 minutes left here. I will end it there unless there's some questions in chat or something like that.
Awesome. Thanks, Drew. If anyone does have questions, now's a great time to put that in the chat. This webinar series is in partnership with our health occupations team, who is hosting their 3rd annual mental health summit. As you can see here on the board, if you want to attend, it is from 7:30 to 4:30 on the 23rd of this month. The cost is $65 a person. So I will make sure to put that information in the chat here for you. And I will also share in the chat the webinar flyer here. So if you want to attend any of our other webinars that are coming up, we do have one on the 10th with Emma Harding from Tanager Place, and then we'll have one on the 16th. And this is more professional development. It is called Torched to Win the Now. Burnout doesn't get the last word, so all about burnout. And then on the 24th, right after the mental health seminar, we're going to be doing resiliency and strategies for thriving with Lisa Schaefer. In that flyer there, you can use that to sign up for all of those webinars, and we hope to see you there. I don't see any questions in the chat, so I'm going to wrap it up. Drew, any final words?
No, someone asked for my my contact information, and so I'll just drop my address in the chat there. And I will be presenting at CoreCon in Omaha, and I'll be doing an opening keynote in Wisconsin later this year, where I will be giving a full presentation on crisis intervention during World War I.
Awesome. Great. Well, thank you all so much for joining us. The recording will be available on our YouTube page sometime next week. And if you have any questions in the meantime, let us know. You can email us at corporatetraining@kirkwood.edu, or you can find us on Facebook and LinkedIn. All right, everybody, have a good day. Thanks for joining us.